Hey everybody, it's Dr. Eric Balcavage. We're back for another edition of Thyroid Thursday, and today we're talking about labs, and specifically we're going to talk about some of the blood sugar labs. And these are three relatively new patients that have come to see me, and I want to talk about why fuller labs are really important. Context matters, and interpretation matters. Okay, so these are three individual clients. They have all went to their primary care physicians, had their general chemistry panel done. The only thing that was done on all three of the clients from a blood sugar perspective was their fasting blood sugar, and their fasting blood sugars were all about the same, 89. Okay, on their doctor's labs, they were right around the same range, but I reran a more comprehensive panel on the patients, and these were the actual values that came up on their blood chemistry panel. Now, we ran a more comprehensive panel. My introductory panel is about 65 tests in urinalysis. So I'm only bringing out a small portion of this, and I wanted to explain why. All three of these clients were told that they didn't have a blood sugar problem, that their blood sugar looked great. And yet, they all had some blood sugar related symptomatology. So when we ran the more comprehensive panel, patient one, fasting blood sugar of 89, patient two, fasting blood sugar of 89, and patient three had a fasting blood sugar of 89. Now what's optimal, kind of like to see the number in that 82 to 88 range, but remember, the value is what the value is. What our job is to interpret it. The lab reference range may be something like 65 to 99, which is really too broad of a range, but the lab value is not the problem. In this situation, we might say that this person's a little bit outside the optimal range. But is that a problem? I don't know, and I can't tell you that by just looking at a fasting blood sugar. Now, all of these clients have some symptoms of high and low blood sugar symptoms. So they all have some challenge with their blood sugar regulation. But we need to take a different look at the numbers. I'm not really worried if the values were 89 and everything else is normal, because just the stress of going and getting a blood draw done for some people is going to raise their fasting blood sugar, and you have a cortisol awakening response that can result in some rise in glucose. So I'm never concerned just about the fasting glucose per se. I always want to see the context. And since all of these people have some signs and symptoms of blood sugar regulation issues, and we need to take a deeper look at what's going on. And I typically never run a fasting glucose by itself. Always run it with other values so you have some context along with their signs and symptoms. So we ran a hemoglobin A1C on all three patients and a fasting insulin. We ran a whole bunch of tests, but just for this purpose, we're going to take a look at these values. So patient one, fasting glucose is 89, hemoglobin A1C is 5.3. Now what's optimal might be 5.0 to 5.3, the lab reference range 4.8 to 5.6 or 5.7 depending on the lab. So this person's doing pretty good with their hemoglobin A1C. Person two, hemoglobin A1C is 5.4, it's a little bit out of the reference range. And person three, 5.6. This person, depending on the lab, might be considered that they're already in that pre-diabetic state. So hemoglobin A1C is a marker of how much glucose is actually sticking to the red blood cells. And so the longer you have more glucose in the bloodstream, the more likely it is to stick to stuff. So that's what we're measuring. And so hemoglobin A1C, even though they all have the same fasting blood sugar, the hemoglobin A1Cs are a little bit different. So just looking at those numbers, even though glucose is the same, we would start to say person number three has more glucose staying in the blood sugar for a longer period of time than patient two, than patient three. Now there's another caveat. We have to look at the hemoglobin A1C in relationship to the red blood cell physiology, but we're not going to do that in this diagram, in this explanation. So we're just going to take a look at these values. And now the next number is really the kind of the telltale sign that there's more significant problems going on, and it's a test that's rarely run. If you want to look at somebody's insulin level, insulin is the hormone that's released when we eat to help get glucose into the cells in a fed state. It should be relatively low in a fasted state because you shouldn't have a lot of blood sugar and glucose in circulation. But if you have some glucose resistance, then the body's going to continue to pump out insulin to try and get the glucose out of the bloodstream and into the tissues. So now we look at person 1. To maintain a fasting glucose of 89, it takes 4.2, we'll call it units of insulin in their bloodstream. For person 2, it takes a lot more. It takes almost 3 times the amount of insulin to force the glucose into the cells. And person 3, it takes a little bit more than 4 times the amount of insulin to get the glucose into the cells and maintain that fasting glucose of 89. So what's going on? Patient 2 is more glucose resistant and therefore insulin resistant than patient 1. Patient 3 is actually even more glucose and insulin resistant, okay? And I don't really like the term insulin resistance as much as I like the term glucose resistance, because even in a fasted state, you're not eating, so something's resisting the glucose from coming into the cell. It's probably less about insulin and more about the glucose. Anyway, we can run a calculation here. We can look at what's called the HOMA index. And if we look at the HOMA2 scoring system, there's a little calculator you can get online. The HOMA IR score for patient 1 is 0.55. That's within the optimal range. So this person really doesn't have any insulin resistance going on. Patient 2, they're at 1.69, which means they are in that kind of developing insulin resistance stage. And patient 3 is in full-blown insulin resistance, okay? So even though their doctor said, hey, you don't have any problems with your blood sugar, everything looks great, it isn't great. In either one of these patients, they're already in a state of glucose and insulin resistance. The medical physician is waiting to see if they have prediabetes or diabetes. In functional medicine, we want to see when this glucose and insulin resistance starts so we can start to address why somebody's starting to develop glucose or insulin resistance. Next calculation on that HOMA calculator, we can take a look at their beta cell sensitivity. How hard is their beta cells working? These are the cells of the pancreas that produce insulin to produce insulin to keep that blood sugar stable. The beta cells in patient 1 are working at about 64-65%. They're not having to work too hard to pump out insulin. Patient number 2, their beta cells are at 140% to try and make the insulin to get the glucose to stay at that level. That's more difficult and more work on the pancreas that says, hey, I gotta make even more insulin, try and force this stuff into the tissue. And if you have glucose and insulin resistance, the tissues that are gonna become glucose and insulin resistance first are probably gonna be the liver, the muscle tissue, and then where does all of the excess glucose have to go when you have this glucose and insulin resistance? It's going to your adipose tissue. And then patient 3, they're at 168%. So their pancreas is working even harder to try and make more insulin to get this glucose out of the bloodstream and get it into the tissues. And the tissues that are going to probably get the most of it is the fat cells. And then you can look at cellular sensitivity. Patient 1, they're at 182.6. So their cells are super sensitive to glucose. Patient 2, their cells are 59.1% sensitive to insulin and glucose, and the patient 3 is 45%. So these two have insulin, their cells are resisting the glucose and the insulin, okay? So why does that occur? Some people say you're eating more glucose than your body can use, and that's why you become glucose resistant, that the cells are full, you eat too much, you don't exercise enough. I'd take a look at it a little bit differently. I think there's some type of cell stress going on. The cells adaptively aren't pulling glucose into the cells, and that's why we have it. Just of note, patient 1, their blood sugar symptoms are the result of something that's going on in their GI tract. That's for another day. Patient 2, they have cellular hypothyroidism going on, meaning that their cells are favoring the deactivation of T4 to reverse T3 versus the conversion to T3. So their free T3 to free T4 ratio is low, but their thyroid gland is producing enough T4. Patient 3, this is a person who's already been diagnosed as primary hypothyroid. They're already on thyroid medication, and their free T3 to free T4 is very low. That means the cells are not wanting to bring glucose in. The cells are insulin resistant and glucose resistant. The cells are also resisting the increased T4. They're not converting it to T3 not because they're broken, not because the deaminase doesn't work, but because the cells are adaptively downregulating the metabolism and downregulating glucose transport into the cell. So this person, despite having normal medication and a normal glucose level, this person's extremely insulin resistant.